I'm Dr. Asim Javed. I'm an interventional cardiologist working at Rawalpindi Institute of Cardiology in Pakistan. This is a series of talks to facilitate learning process for performing mechanical thrombectomies in acute ischemic stroke. According to WHO, there are 16 million strokes that occur per year worldwide. AHA 2021 figures, on average, someone dies in USA of a stroke every 30 minutes and 33 seconds. That's about 405 US deaths from stroke each day. Now, this is a very scary figure that comes from European Cardiovascular Disease Statistics 2017, according to which globally every fourth person aged over 25 years will suffer a stroke in their lifetime. What's the natural history of stroke? Two-thirds patients either die or are moderate to severely disabled for the rest of their lives, and only one-third patients are lucky enough to have minor disability or recover fully. Now, 88% of these strokes are ischemic strokes, out of which 77% are non-lacunar, and then 35% strokes are cardioembolic strokes. Large vessel occlusion means abbreviation is LVO, which will be used again and again during the talks. So large vessel occlusion stands for occlusion of internal carotid artery, middle cerebral artery, or basilar artery. Why these three are important? Because they have a bad prognosis. Internal carotid artery occlusion means a mortality rate of around 50%, and basilar artery is around 90 to 95%. What happens if you do not intervene on them? So if you do not intervene on an MC occlusion, you could have a malignant MC infarction, which would mean life-threatening brain edema between second to fifth day of stroke, and case fatality goes up to 80%. Conservative measurements like hyperventilation, mannitol, there's not sufficient evidence to support their use. So what happens with edema? You can see here that there's a lot of brain edema and it's compressing the ventricles, and then slowly gradually it starts compressing the other side of the brain, and you've got transtentorial and tonsillar herniation. So what needs to be done at this stage is decompressive hemicraniectomy, because you need to create compensatory space for the brain to accommodate. Now, the first revolution in stroke treatment came in 1996 when, based on NINDS and ECAS trials, US FDA gave approval to alteplase as thrombolytic within the first 3 hours of symptom onset. But we do know that with thrombolytics, there are time constraints and there are so many exclusion criteria, and then most importantly, it's best for small distal vessel occlusions and not for large vessel occlusions. So if you look here, internal carotid artery, the recanalization rates are around 4 to 8% with thrombolytic. But as you go distally in the MCA territory, then it can go up to 30 to 40% success. We also know that longer the clot, less effective the thrombolytic would be, and this study has shown that less than 8 millimeter thrombi are most effectively treated with recanalization. People started thinking of doing mechanical removal of clots very long time back. So this is a case report published in year 2000 where they used a micro snare to remove a clot from the MCA, and you can see that they effectively recanalized the MCA. Then came Mercy device in 2004, but again it did not prove very effective. Solitaire AB was a stent which was designed by Lebig and Henkes, and it was basically designed for stent-assisted coiling. But then it was used for mechanical thrombectomy and found to be very effective. So the endovascular stroke treatment has actually gone and undergone an evolution from Lytix to Mercy device to Penumbra, then stent for stroke, and now we have the current generation of stent retrievers. So 2015 was a game changer with Mr. Clean, Escape, Extend IS, Swift Prime, Revascat trials coming out, and all of these trials showing the clear benefit of endovascular treatment over intravenous TPA alone. This was the second revolution in stroke treatment. And for the safety, they showed that mortality at 90 days and the risk of symptomatic intracerebral bleed did not differ between the populations. Now, mechanical thrombectomy got added on to the TPA treatment because we know that TPA only works on small clots and in the distal vessels. And if you have IV TPA on board, then the large clots are removed mechanically, and the residual small clots, if any, they get, or the distal embolization that you get during the mechanical thrombectomy, that gets treated by the IV TPA on board. Now we can see the clear benefit of endovascular treatment in these trials. Mechanical thrombectomy was proved to be highly effective and safe treatment of acute ischemic stroke in patients treated within the first 6 hours from symptom onset. Now this graph is looking at physical functional outcome at 3 months, and MRS 0 to 2 means an almost functionally independent person. We can clearly see that mechanical thrombectomy with TPA arm in red is superior to the TPA alone arm in gray. We can also see the different criteria that were used for patient selection in each trial, starting with Mr. Clean, which used non-contrast plain CT brain, going on to Revascat and Escape that used aspect score on CT, and then Swift Prime and Extend IA, which used CT perfusion for patient selection. So we can see that as we became more selective with the patients, the result outcome improved from 33% of Mr. Clean to 71% of Extend IA. Now, if you look over here, what I mentioned is that the functional independence that was achieved in only 40% of patients in TP alone arm versus 71% in thrombectomy arm means sending people home independently. Now, in natural history trial, mortality was 80%. Looking at this is the natural history trial, whereas the highest mortality, even in Mr. Clean, that went to 18%. So you can see that endovascular treatment definitely has a major role here. Then in natural history trial, MRS 0 to 2, which is functional independence, is achieved in only 5% of patients, if not intervened, whereas in interventional trials, this was achieved in 60 to 70% patients. Now the time window concept is going away, and this is what was shown in these two trials. What they did was that they added perfusion imaging in case selection and in fact became super selective, and they got excellent outcomes. So in comparison to medical arm, the thrombectomy arm was still better even in these late window trials. Now there was no subgroup who would not benefit from mechanical thrombectomy in comparison to control group. Now this is data looking at mechanical thrombectomy in patients less than 75 years of age and in patients more than 75 years of age, and it clearly showed benefit in all subgroups. Now, another important question is there a benefit of thrombolysis as bridging therapy as compared to direct mechanical thrombectomy, and hence shortening door to groin puncture times? Now, Hermes meta-analysis showed that there was no difference in outcomes if the patient received TPA as a bridging therapy or went straight to mechanical thrombectomy without getting TPA. Now, these randomized control trials came out, and amongst these, the two Chinese trials, that's the direct MT and the DEVIT trial, showed non-inferiority of mechanical thrombectomy versus mechanical thrombectomy plus TPA. But the Japanese trial, SKIP, could not prove this non-inferiority. Then came the SWIFT Direct and EMMA and Mr. Clean no IV trials, and they failed to show non-inferiority of direct mechanical thrombectomy versus bridging therapy, meaning TPA plus mechanical thrombectomy. So based on these, 2021 European Stroke Organization guidelines state that they recommend intravenous thrombolysis plus mechanical thrombectomy where the patient qualifies for both treatments. So not going for mechanical thrombectomy alone. Now this is a meta-analysis of 3 trials: Extend, ECAS 4, Extend, and Epithet, which have recommended extending TPA window from 4.5 hours to 9 hours using CT perfusion imaging. And then the same was shown in BICUP trial based on MRI. So now 2021 European Stroke Organization guidelines have come out with the criteria that for patients with ischemic stroke presenting between 4.5 hours to 9 hours duration and with CT or MRI core perfusion mismatch, and for whom mechanical thrombectomy is either not indicated or not planned, they recommend IV thrombolysis with alteplase. So they've actually extended the time window to 9 hours from 4.5 hours for IV TPA, but based on CT or MR perfusion mismatch criteria. So now this is again the latest guidelines, according to which if the patient presents to a center within 4.5 hours of symptom recognition for wake-up stroke, now this we are talking of wake-up stroke, caused by anterior circulation, large vessel occlusion, then they suggest intravenous thrombolysis plus mechanical thrombectomy over mechanical thrombectomy alone in selected patients, and selection is again based on CT perfusion and MR criteria. So the time windows have been increased from 2019 now, but we will see this later on in the next talks. Again, European Stroke Organization guidelines for patients with acute ischemic stroke waking up from sleep who were last seen well more than 4.5 hours earlier, who have MRI DW1 flare mismatch, and for whom mechanical thrombectomy is either not indicated or not planned, then IV thrombolysis with alteplase can still be given. Now, this is subgroup analysis of 2015 trial that shows that if we reopen a blocked brain artery within 2 hours of symptom onset, the recovery rate is 90%. This means time is brain. Now, if you look at the time of is brain concept, if you look at this NINDS placebo arm, you can see even if you have placebo and there is no IV thrombolytic on board, still a lot of patients do benefit. But if you give IV TPA within 3 hours to 4.5 hours time window, number needed to treat goes down to 14. You have some more patients who get the benefit. And giving thrombolytic between 1 hour to 1.5 hours, the number needed to treat drops down to 4.5. And from if given within the first hour, number needed to treat is only 2. Now, these are some important figures here. If you look at primary PCI versus IV thrombolytic and STEMI, you need to treat 45 patients to prevent 1 short-term mortality. And now mechanical thrombectomy versus IV TPA, you only need 29 patients to prevent 3-month mortality. But this is a very eye-catching number. This is IV TPA with mechanical thrombectomy versus IV TPA alone in acute ischemic stroke. To bring 1 patient back to functionally independent life, number needed to treat is only 3. Now, this is a tremendous figure. So, realizing the importance of time, this is what BEST is doing now. These are mobile stroke units. They've got CT scans fitted in these ambulances, and once they receive a call from home, and if they suspect a stroke, they will dispatch one of these ambulances which will do the CT scan. During the transit, they will transmit it through telemedicine to the stroke center, and then the center will immediately decide if the patient needs to go to a mechanical thrombectomy place or it needs to come to a thrombolytic alone service. Whichever way it needs to be done, the decision is taken there and then. Now, you can see that majority of the world does not have a mechanical thrombectomy center, and out of a total of 2,000 centers, 78% are in US, UK, Brazil, France, Germany, and Australia. I was listening to a talk the other day from Ireland, and they said that they had only 2 mechanical thrombectomy centers in the whole of Ireland, but the value of life is such that they do all the CT perfusion imaging and everything at the center where the patient presents. And then if the patient qualifies for mechanical thrombectomy, they airlift the patient and bring them to those 2 centers. Now, who should be doing mechanical thrombectomy? Now, that's an important question. Is it only meant for interventional neurologists? Why not? If you have sufficient number of interventional neurologists in your country, by all means, they are the ones who should be doing it. But since interventional neurology is not very well developed, especially in countries like Pakistan, developing world, where we can count interventional neurologists on our fingertips, and hardly 1 or 2 cities have them. Rest of the Pakistan is without them. So who will do this mechanical thrombectomy in these countries? So that's the question that came out. The answer came in 2018. This is Europe PCR key messages from the inter-society meeting of European Stroke Organization, European Society for Minimally Invasive Neurological Therapy, European Academy of Neurology, European Society of Neuroradiology, Stroke Alliance for Europe, and European Society of Cardiology. Now, these are their slides that I'm showing here, and this is what they said, that these are the places where already interventional cardiologists are doing stroke interventions along with neurology. So these are South Africa, Czech Republic, and then Turkey, USA, Netherlands, Slovakia, Germany, Portugal. And they also said that training of new interventional neuroradiologists would take more than 2 to 3 years versus training of the experienced interventional cardiologists, which can be as short as less than 2 to 3 months. Who is an experienced cardiologist who should be doing it? anybody who's completed his interventional cardiology training and has at least 3 years experience afterwards. There's documented experience with carotid angiography, more than 50 DSA procedures, and carotid stenting more than 25 as primary operator. Now, who should be doing independent then as a cardiologist? Independent mechanical thrombectomies. For that, you need to be doing cerebral angiography or carotid stenting at least 75%, 70 cases. Then second operator in mechanical thrombectomy, at least 25 cases you should have assisted. Then first operator role under supervision in mechanical thrombectomy for another 25 cases, and then you can start doing your independent cases. They've also suggested quality control for these mechanical thrombectomies, and that should be kept an eye on. So successful recanalization in at least 60% of cases should be achieved. Embolization to new territory should not be more than 15%, and symptomatic intracranial hemorrhage of less than 10%. Now, I'm going to show you an interview of Professor Nick Hopkins, who's one of the pioneer neurointerventionists, and he was the chief executive of Gates Vascular Institute, Buffalo, New York, where I got trained for this stroke intervention. And this is what he has to say about interventional cardiology's role in neurointervention.
2018. My name is Mark Abelson. I'm an interventional cardiologist from Cape Town, South Africa. And with me is a very honored guest, Professor Nick Hopkins from Buffalo, New York, who's a neurosurgeon and pretty much pioneer in the field of stroke intervention. The need, because that's the issue, is getting cardiologists involved. What training do they need? And there's a lot of legislation issues, I think, but there is a pushback by the neurointerventionists to not have cardiologists involved. But in the short term, millions of people are suffering, and what do you think about the training programs?
Very interesting topic, because if you look at the neurointerventional community guidelines, they look like a simple turf barrier, but in reality, the way they were designed originally was for first-time users, because the person who goes through a neuroradiology residency, he hasn't done much of any catheter intervention when he gets to his INR fellowship. So the fellowship guidelines are really designed for starting from scratch. And what I think they ignore is the fact that interventional cardiologists are very skilled at catheter interventions. As a matter of fact, if you think about what do cardiologists do all day, they open up occluded arteries, exactly what we need for stroke. But they do it on an awake patient in a moving target, because everything's moving in the heart.
With bifurcations and lots of calcium. To end, Nick, where do you think this field is going? Just to summarize and...
Yeah, that's a great question. I think, if you look at the fact that there are 16 million strokes in the world, and if you look at the number of neurointerventionalists that are available to treat them, it doesn't even treat a small fraction of all the strokes. So we've got to have help from our cardiology colleagues to handle the public health issue of how do we treat these patients. If we can return a patient from aphasic and hemiplegic and completely out of it, nursing home candidate, if we can return that patient to an essentially normal life, it's a huge benefit to the public health. So we have to figure out a way to satisfy the public health, ignoring turf, and working on ways to get cardiologists enough training to understand the basic needs for opening up a cerebral artery.
Rawalpindi Institute of Cardiology started to go into this stroke intervention program. We started with training on simulators and 3D flow models and animal labs in Malaysia, and then went on to training for stroke to comprehensive stroke centers USA in Buffalo, New York, and then West Virginia. Now we've got TPA available for these patients. We have our own neurologist who does the case selection and then the post-procedure care for these patients. We have a neurosurgical backup. We've signed an MOU with our neighboring hospital with the neurosurgery department. We've got a 24/7 CT scan service. We have currently 128 slice CT, and our 640 slice CT is in the process. We've got a 3 Tesla MRI, and we have our own rehabilitation service. Now, 13th April 2018, the first case was done at RIC, and we've not charged any patient any money. So 65-year-old man, 90 minutes history of left-sided hemiplegia. This is pre-thrombectomy. You can see middle cerebral artery occluded here, and there is no brain circulation, any blood vessel visible on this side. And whereas After thrombectomy, you can see all the blood vessels coming back. This is the lateral view, in which you can again see an empty space here. This is where the MCA is occluded, and then after recanalization you can see that all the blood vessels are back, and this is the material that came out, and this is the patient maybe this is an hour or 2 hours later.
ਲੱਤ ਉੱਤੇ ਚੁੱਕ ਕੇ ਦਿਖਾਓ ਜੀ ਲੱਤ ਚੁੱਕੋ ਉੱਤੇ ਠੀਕ ਹੈ ਜੀ ਥੱਲੇ ਕਰ ਲਓ ਜੀ ਥੱਲੇ ਕਰ ਲਓ ਥੱਲੇ ਕਰ
So
ਲਓ
you can see you can really get a miraculous recovery if the patient comes within time and you're able to open the vessel. Now this is a 30-year-old lady with peripartum cardiomyopathy and ejection fraction of 15%, came in with 3 hours history of left-sided hemiplegia. You can see the blocked MCA here and the brain circulation is all missing on this side. Post thrombectomy we used the stent retriever and you can see all the vessels are back. And this is the lady at the time of discharge. I think it was the 3rd day and she's going back home.
ये बाजू ऊपर उठाएं पूरा शाबाश दूसरा भी उठाएं ऊपर ठीक है दांत दिखाएं ऐसे.
So you can see again miraculous recovery. Now this is a very interesting case. 30-year-old gentleman with 18 hours history of paralysis of all 4 limbs. He was way beyond the time window. Loss of speech, unresponsive. He had very difficult time breathing, and we had to place him on a mechanical ventilation. So clinically, he was a posterior circulation stroke. Now we do know that with basilar artery occlusion or posterior circulation stroke, the mortality ranges from 90 to 95% if not intervened. Likelihood of good functional outcome without recanalization is only 2%. So, but on the other hand, he was way beyond our 6-hour time window. So what to do now? We are almost losing the patient and chances of recovery are very less. He's very young. We were very early into our program at that time and we thought we should not intervene. He's beyond 6 hours time window. We need an MRI to see the viability of brain and all, and then we can go on. Otherwise we can't. And at that time, one of his colleagues he was a laborer by profession, and one of his colleagues who had brought him walked up to us and he told us that he's a very, very poor man. He's got 3 young daughters, and if we don't do something for him, those 3 daughters are going to come onto the roads because he has no other help available for the family. He said it in such a way that, I mean, it was very difficult then to resist, and me and my neurologist looked at each other and we immediately decided we need to intervene on this patient. What have we got to lose? He's going anyways, and if we can do something for him, maybe we can help him out. So we took him for the CT angio. We saw the occluded basilar. We took him to the cath lab. We saw the basilar artery occluded here. I did simple aspiration, no stent, just went in, took the thrombus out, aspirated, and we've got the open basilar. And this is immediately next morning. He's off the ventilator. He's able to move his right side of the body, but his left side of the body is still not moving, so it does take some time to recover at times. But then this is 3 months later. Same patient sitting in the office of our neurologist. He's communicative, aphasia is all gone, and he's fully functional, and he's gone back to his normal profession. He's a laborer again. So what is important? What is important is time is brain. This concept is really important. In cardiology, we say time is muscle, time is brain here. At the end, I would humbly request my audience to just think for a second that if tomorrow, God forbid, you or one of your loved one has a stroke, where would you take them for treatment? What kind of treatment would you want for them? Now is the time. As interventional cardiologists, we have the capability, we have the potential. All we need is the will to learn this intervention with the motive to help our community, to help ourselves. And till the time interventional neurology in Pakistan is able to come up and fill up the vacuum, till then I think interventional cardiology is the most suited and the only option available here in Pakistan. We all must join hands with interventional neurology, cardiology, neurosurgery, interventional radiology, and together we should work to reduce the misery, the morbidity, the mortality associated with this stroke. And now in 2022, this is doable. These large vessel occlusion strokes that are the bad ones, the worst ones, they are the ones that are reversible now, and nobody has to live with the disability for the rest of his life. So it's all about teamwork, and that's the way forward. Thank you very much.